Well, thanks so much, Rio. Welcome, everybody. Thanks for coming in and listening to my topic. This is something that I'm really pretty passionate about. It started as my career as a paramedic myself before I got into teaching. It's always been a passion, but even more so since I've left the field and went teaching full time. As of today, I've lost 12 different colleagues from post-traumatic stress and suicide. So this is a topic that's really I'm really passionate about and I hold dear to my heart. So I decided, what can I do to change some of the course of our career paths, and at the end, when it seems to be a struggle for at least my colleagues that I'm familiar with. And I decided to start looking at paramedic students to see if there was something I could see that students were starting to experiencing post-traumatic stress type reactions as a result of, I don't know what. At first, when I started, more and more I started having students come up to me saying, hey, I was on this clinical rotation and I'm just having trouble sleeping and I can't, I just can't focus. And as I've continued throughout my career, this seems to be happening more and more and more. And after COVID, as it probably not shocking to everyone, it seemed to continue to increase, but at a little bit faster pace. So with that being said, I started to really look into this to see if this is really a thing or if it's just my imagination. Based on my experience, I assumed that it was probably something, but I didn't really know even where to start. So with that being said, I just kind of started off with the simple question of, is this even really a problem? And, I just thought, well, maybe students are struggling from being students, which is very possible. Lots of students are brand new to this and they're, some are 18 years old, some are, not, some are non-traditional, traditional students. At Creighton University, we have a certificate program and a bachelor's degree program. So we have lots of students that are traditional as well as non. So I wasn't really sure if that was part of it or what the whole thing was. So I just decided to jump in head first and kind of see where it took us, and kind of just looked at what we could do to potentially make a change and do something better. So kind of our unofficial study that we started to look at and are still, and just so you know, we're continuing to study this. So this isn't over. This isn't a study that's ready for publish. This is still kind of a study that's in motion that we're still continuing to look at. So some of the things we wanted to look at is determine patient interactions that may cause traumatic stress. So what is a call that you would think that an 18-year-old student, sometimes it's hard not to say kid because 18 seems young to me now, but even an 18-year-old student or even a 25 or 35 or 45-year-old student may cause traumatic stress. Okay, so we wanted to look at those calls and categorize those and kind of look at those closely, which is just basically our faculty got together and decided, hey, what kind of calls do we think that could cause stress to students? Next, we wanted to determine the number of paramedic students that came up to us and sought assistance, whether they came to me, whether they came to our clinical coordinators or our lab coordinators or even our paramedic program coordinator, or just really anyone that came looking for someone to talk to or some direction on how to move forward. Then we wanted to explore mental health options for students. Obviously, I'm not a mental health practitioner or clinician. So, what are the options for these students? And what do we do when they come to us with more than something than I'm just having a little trouble stopping thinking about this call, or this was a really interesting call, but it kind of bothers me. What do we do with the students that are having some severe problems that can't sleep, can't stop crying, can't stop things like sort of the more acute problems? What options do we have on campus or even off campus for them? Next, we wanted to examine even our paramedic mental health curriculum. So are we preparing students not only for self-care, but also to take care of patients that are having mental health crisis? Little kind of a side note. But really we also wanted to explore that, because again, if you have 18-year-old students, how are we preparing them to even care for people with mental health emergencies in the field? So Not necessarily what I'm talking about with post-traumatic stress for students, but also we wanted to add maybe some mental health education for them in their curriculum. Next, we wanted to explore opportunities for educational intervention. So what are some things that we could help with them to be ready, and what are some things that we could prepare them for, or help them prepare for what they're going to see in their career or even in their clinical rotations. So that's kind of where we just took a big chunk out and just started working on this, just to kind of see what data we could come up with. So first, determine the patient interactions that may cause traumatic stress. So these are the calls that we decided as faculty that we thought may potentially cause traumatic stress for a student. So we went with deceased on arrival, domestic violence, cardiac arrest, MVA, MVC, trauma. So dog bite, burns, falls, gunshot wounds, and this is kind of our other category. A ground level fall, which sounds probably mundane for most of us that are experienced, but maybe not potentially for a student. An overdose, a suicide or attempt, and then a psych interaction, a mental health interaction where the patient is having a acute psychosis. So these are things that we wanted to look at, and these are the categories that we chose. So here are the numbers of the students that we chose to look at. We only chose to use one cohort at this point, just because we just kind of want to get a start. And so this cohort had 33 students in it, 33 paramedic students in our traditional paramedic program. We mix our degree-seeking students and our certificate-seeking students. So most students don't know who's a degree seeker and who's not. So, I mean, obviously we don't tell them. I'm sure they know based on talking with other students, but nonetheless, the cohort of 33 students are mixed. And then we looked at potentially stress-inducing traumatic patient encounter averages for each category. Now, I wanted to say this, and I wanted to throw this out there. I'm not affiliated with FSDAP. I'm not making recommendations. However, this is where we got our data from, is a retrospective student-centered entered data gathered from FSDAP. So that can mean a lot of things. It's retrospective, so it's what they had put in their FSDAP accounts, and it's student entered. So as we all know, students enter everything 100% correctly all the time. Just kidding. But that's where we got our data. So our findings is where it starts to get interesting from my perspective. So deceased on arrival students averaged 2 and a little bit better than 2.5 contacts per student, with a total of 74. So that cohort of 33 witnessed 74 patients that were deceased on arrival. A potentially traumatic event for anyone, but 18-year-old kids or students, it could be even more interesting. So domestic violence, 3.66 with a total of 107. Cardiac arrest, they averaged 2 per student with a total of 61. MVAs, 11 for a total of 346. Trauma, 7.5 for a 240. Ground level fall, 12.5 for a total of 400. As you can see, 8.6, 275, 1.75, 46 total suicide attempts. Psych patients, mental health encounters, 5.25 for a total of 137. So we started looking at these numbers and was sort of overwhelmed, like, how can these students not have some sort of post or traumatic stress as a result of these numbers? These numbers were pretty astounding to me. Now, of course, these are averages, so maybe not every student got to witness a cardiac arrest, but on average, they each witnessed 2. So those are fairly significant numbers, and things that sort of made us raise our eyebrows of, oh my gosh, these students really are seeing traumatic things from our perspective. So, and again, Maybe some aren't affected, but there's certainly the possibility of being so. So that's what we're looking at. Here's the other numbers that were also alarming to us. Each student had an average of 55 patient encounters determined to be potentially traumatic stress inducing. 55. The cohort had approximately 1,685 total patient encounters that were determined to be potentially traumatic stress inducing. So what does that tell us, and what are we thinking from those numbers? Well, my take away from this was that these students are, if we talk about their neurobiology being fully developed at 25, a good majority of our students are less than that. So 55 patient encounters with really no preparation. I mean, we're not, and I'm assuming, I guess, most paramedic programs that I've been associated with or know of aren't necessarily preparing students what I would call adequately either to encounter these types of numbers. And I think most of it is because we don't know how. When I went to paramedic school too many years ago, we didn't talk about this kind of stuff. This is part of the job. This is what you signed up for, and that's just how you're going to have to deal with that. Well, as we're finding, people at the end of their careers have so much of this stuff stored in their brains that they're finding suicide as a suitable alternative. So I think if we can change this from a student perspective and get students looking into self-care and how we can prevent this, potentially we can change at least the, sort of the environment that these students are entering. So with that being said, those are the numbers that they're seeing. This is another kind of interesting slide, is that the percentage of students, just over 30% of those students of that cohort sought mental health support from faculty and beyond as a result of a clinical experience. As you'll see a little bit later in the literature that we've looked up, 10 years ago, or even a little bit longer ago than that, it was around 20% as average. Now just our numbers, 30% is higher. Is that just a coincidence, or is there some real value in looking at the COVID pandemic and how that's caused students on our university to seek more mental health support as a whole, not even as a result of clinical experiences, but really just in life in general? People are having more mental health issues. So you couple that with these students that are seeing traumatic things in the clinical rotations, and it really worries me as a program director and as an educator, just like all of you, as to how many what's going to happen to these students, and how are they coping, and what are some of the options out there for them to help them. Because I'm sure you can all attest or relate as a program director what a tragedy it would be if a student decided to end their life as a result of just doing clinical rotations. And I know it's happened out there. It hasn't happened to us, knock on wood, but it's something that really terrifies me every day to think about the possibility of this happening. So with these numbers, not necessarily, sort of a panic ensued of, okay, well, we need to establish something of what we can do for these students when they're having problems, and when they come to us to talk to us, what can we do? So here is, at least at our university, the opportunity for mental health services for students. So this is kind of dually lined. This is if a student comes to themselves. You can see my cursor, I'm assuming, when they come in and screen and just say, hey, I need to talk to somebody. And I like this graph because it shows the time and energy required of the students is more and more. If they want to come make these appointments, it's going to be on them to come here. As we start to encourage them to be more an advocate for themselves, and as it gets more and more problems, it becomes a bigger deal, to where some of these workshops are helping them with some anxiety and stress relief. Group therapy, there's all kinds of this. Online therapy is something that's available 24 hours a day that students, interestingly enough, have said that was very helpful for them. As shouldn't say this perhaps, but skeptic about this, of what is going to happen for somebody who's in a real acute sort of mental health crisis, if you will. I'm really worried about them doing something online, and if that's sufficient. But the students seem to have found value in these things up here, the individual therapy. Now, that said, so as a paramedic, and in my experience with other paramedics experiencing traumatic stress, some of the mental health people, social workers, et cetera, that they were sent to weren't necessarily prepared for first responder type traumatic interactions. So we've talked to them. Myself and our faculty have met with the student life people and the student counseling services to, what do we do if the student, are you prepared to talk to students who have witnessed a suicide, who have witnessed something in a clinical rotation that's beyond perhaps your social worker expertise, if you will. That was naturally one of my worries as a program director. Are we sending students to a social worker that's not prepared for what they're going to hear? Now, that being said, and the reason why I say this, and maybe some of you who are listening have had this interaction, but I've had colleagues that have been sent to a social worker as a result of a traumatic experience. And when they were talking to the social worker became emotional and asked the person to stop. They weren't prepared to hear this and aren't prepared to help. I didn't want a student to be involved in that situation and feel as though they were alone or out on an island. So I wanted to make sure this was an opportunity for them that was going to be helpful. That being said, we also sort of partnered with the First Responders Foundation. Again, this isn't an endorsement. This is just who we have available. So we've sent a couple students to First Responder Foundation. And the reason is because they can handle acute issues, not necessarily with any time frames. They're willing to meet with students in an acute phase, which has been really helpful. The people that meet with them are first responders turned social workers typically, and have experience in post-traumatic stress from a first responder perspective. So we've had great success with them as well. Between both, the last one from the university themselves, and between them and the First Responders Foundation, we've found great success with opportunities for our students. That said, switching a little bit of a gear here, we decided to look at our paramedic mental health curriculum. And this was a bit unnerving as well, but we spend, and this is just our curriculum, yours may be different, or maybe the same, or maybe less. It's just how it's set up right now. So we have 1 hour of well-being of the paramedic, which is kind of in our introductory phase of our program, where students talk about well-being. This is where we measure their resilience. We have them fill out sheets on goals, and we actually even measure their strengths through via Strengths Finder, kind of like the Gallup Strengths Finder type thing, just to see where students are. And then we look at 2.5 hours of behavioral emergencies and restraints towards at the end of the medical emergencies section of our curriculum. So 3.5 hours of mental health. Now, I brought this chart in here too, that isn't necessarily for student post-traumatic stress, but it also looks at kind of the context that students are seeing out there for depression, patients calling with a mental health complaint. So these are cohorts. These are P122 all the way up to P125. As you can see, 425 cohorts for 21 students. Now, if you look at these numbers, they look like they're climbing significantly. Well, so is our enrollment. So they're about the same. There's 20 per student, 15 per student, 22 and 23. This one that's real low is 15. Our requirements were lower for COVID. Our contacts were lower just because of, as everyone knows, and struggled through COVID with clinical rotations and where we sent students. So But this too is significant. We talked about the things that are causing a student, or the things, the experiences, the interactions that are causing students post-traumatic stress. Well, here's 20 to 25 contacts per student of someone having a mental illness. And as you know, as paramedics or first responders of whatever level, our mental health capacities for patients is pretty limited. What do you do as a paramedic when you show up on a scene and a patient's complaining of feeling depressed and even suicidal? Well, typically in the systems, it's better today because we're having response units with mental health responders and that sort of thing, but it's still very small. The patient ultimately has a decision to make whether they go to the hospital with the ambulance, or they get put into emergency protective custody by law enforcement. So, when you think about that as a patient with a mental health complaint, those are your two options. It doesn't really build trust much for the medical community. And, what do? We get them in the back of the ambulance and tell them to trust us. We're here to help them, when we've just essentially abducted them. Now I understand all of, the consent and everything else like that, but really there's got to be a better way to help take care of these patients. And then we get them to the hospital, to where the place we've taken these patients, and those medical practitioners are also asking this person to trust them when we've essentially brought them there against their will. Not always. I mean, this is just worst case scenario. But are we really even preparing our students to handle those sort of circumstances? For me, that's unnerving. I don't know if our students are even ready for this. And as everyone can probably attest to, or at least through experience or seeing, mental health cases are increasing all the time. The problem is I remember in my career way back when, stroke care was not like it is today. Today, it's a full-blown emergency when someone's having stroke symptoms. It used to be we took them to the hospital and hoped for the best. Well, I think mental health, not that it's as acute and as deadly potentially, which it could be, but it's becoming an emergency of what do we do with these people? There's so many people complaining of mental health complaints, and we have so many practitioners in the pre-hospital area that aren't ready or educationally prepared. Of course, this is just Ryan's opinion. I think we could be better. So how can we marry a lot of the things that we do in the pre-hospital world, we marry from the in-hospital world to help a more smooth transition. And mental health, I think, is a place where some more work is needed. So then we explored opportunities for intervention. So what can we do to try to help increase the education, both with mental health complaint patients or even personal well-being for our paramedic students? I didn't mean to kind of cross over these two things, but I think there's some relation to those. So, when we looked at some different opportunities, we looked at resilience measurement and education. So first, how do we measure their resilience? Well, there's a couple tools out there. One of them is the Wagnall and Young measurement tool. It's a bit old, but it's still very valid, and it's a questionnaire that you can use to help measure their resilience. Interestingly enough, I've been using that tool for probably 5, 6, 8 years, and it's very predictive. It's very accurate to students that experience problems. It's actually weirdly predictive to even GPAs. People with high resilience scores typically are high achieving academically as well. Typically, I say not 100%, but probably above 75. So that's interesting. But then how do we start to educate students? And I'll talk about here in a little bit with our experienced students and what that looks like from resilience from that perspective. But really, students that have no experience, that are just out of high school, that are wanting to be paramedics, how do we educate them in resilience? And what does that look like? And is it effective? Can students learn to be resilient? That's an interesting thing for us to continue to consider. Enhancing mental health education in the paramedic curriculum. I know this is something that I struggle with. I'm sure you're all like, yeah, right, Ryan, where am I going to add that? I'm already packed full. But I think it's valuable. I think if we can add more robust mental health education in our curriculums, potentially we can take care of our patients better and potentially even ourselves. So things to consider there. Exploring and creating an additional certification for mental health paramedics. This is something I'm working on kind of on the side of this, but I think that potentially having a mental health designation for paramedics as a postgraduate type thing, similar to critical care or flight paramedic certifications, may be valuable for mental health. Paramedics are experiencing mental health patients every day, multiple times a day, with 1 to 2, maybe less hours of mental health education. Potentially that would help. Now I know there's specialized teams, and where our university is in Omaha, there's a specialized team that contains a social worker, some law enforcement, first responder type people that come out in these acute mental health calls that have been very helpful, but they're not out there. They have to be sort of dispatched and everything else. So how do we make that more streamlined? And is maybe having mental health certified paramedics a strategy? Next is explore opportunities to enhance overall well-being and healthy lifestyle education within the paramedic curriculum. So we talked about adding mental health additional certification potentially, and even mental health, but what about well-being and healthy lifestyle and positive psychology and grit and resilience, all the buzzwords that are out there today? Where do we add that into paramedic education, and is it valuable, and should we? What did we all do long time ago, if you're an experienced person that went to education to enhance our well-being? Not every time was it positive or even healthy. So how can we help students explore ways to enhance their well-being, and what does that look like, and what does that even mean? And how do we destigmatize all this stuff? We'll talk about that a little bit later too, but there's a lot of people that would look at this and go, oh brother, really, you're gonna have to sit around and sing Kumbaya, huh? Well, I think there's some value in that. I think students are struggling today with mental health issues just to be alive in today's world that we all discuss. And we've watched the world change where they've sort of grew up in this, and what is this world, what is happening here? So something to consider as well. Also, just enhancing our overall trauma and traumatic experience education, not trauma like injured people, but trauma like trauma of mental health trauma. I also, on the side of this too, teach in the prison systems in Nebraska about trauma and shame and vulnerability in the prison system. And it's always interesting to me as what happened to these inmates in their prior life that caused them to have trauma and traumatic childhoods and those sort of things. And we'll talk a little bit later about ACEs scores, and we measure them in the prison systems, and their numbers are astounding. It's almost not a shock that this is where they're at today. And if we can see a student that has a high ACEs score and a low resilience score, I think it's a safe bet that person could easily have traumatic stress, or at least have an easier opportunity for traumatic stress than perhaps someone else without those scores. So yet, more research opportunities, but something else to consider. So then we looked at the literature, like what does the data say about this? I just pulled a few studies about this just to not overwhelm you with data and research, but it was pretty interesting about what the studies have said out there. This study from Australia in 2021, a really new study, said the primary stresses of paramedic students were experiencing death and the fear of making clinical mistakes. Students also identified emotional expression as a negative attribute. These are things that to me, that's why I put this data first, because I really think this is fascinating. So students experience stress from experiencing a death, but also they're scared of making a mistake. How do we help them to be more confident? Now they're students, so they're obviously going to be feared of making mistakes. That I understand. But the thing that really confuses me and frustrates me, if you will, more is students also identified emotional expression as a negative attribute. So what that tells me is that if students are experiencing this in every clinical rotation, these are the things that are causing them the most stress, but yet they don't know who to talk to about it, or don't want to talk to about it because the people that they're with aren't experiencing those same stressors. So how do we destigmatize that? How do we get students to say, hey, you know what, I'm having trouble and I'm really scared I'm going to make a mistake, which, we as educators and clinical educators know that most of the time, I'll say, they're with people that are watching them to not let them make mistakes. That's the whole point of the clinical process. And experiencing death is something that they're going to do probably as well. I mean, in our students that we looked at, every one of them experienced a code or an MVC or a death on arrival or a suicide attempt. So if they're already stressed about experiencing that, you can imagine how stressful it even becomes, and then it's not even okay for them to talk about it. Next article from the United States. This is pretty old. This is in 1996. We knew, which is 20 years ago, better than 20 years ago. Analysis indicated that 20% of experienced paramedics and 22% of paramedic students appear to be suffering from trauma. Now, 20%, we saw 30% in our class, and those are the people that actually came for help. So is 20% accurate, especially in 1996? I would question the data on this, just because if we're talking about emotional well-being and people looking down upon that, I would imagine those numbers are probably much higher, but people are just not interested in talking about them experiencing trauma. Next, in 2019 from Australia, currently the majority of the measurement tools used to assess post-traumatic stress are only still aligned with superseded diagnostic criteria and may only classify the symptoms of PTSD as a present or absent, with little consideration given to symptom severity. Consequently, these existing measurements of PTSD are outdated and inefficient in their ability to identify and measure PTSD using the revised criteria. So basically what this is saying is that most of the diagnostic criteria for post-traumatic stress is still, number one, a disorder, not an injury. But number two, you either have it or you don't. There's no varying degrees of it. And we all know what happens if you're on the job or you're out on the department or something to that effect, where you're out taking care of patients every day and you're labeled with post-traumatic stress disorder, what that means. There's no variance of, well, I've had an injury from a call that bothers me, but I'm still able to function. I'm still able to do my job. I just have some trouble once in a while. There's no varying degrees. So again, no wonder people are not interested in talking about this, because if they get labeled with a psychologic disorder, that seems to be potentially a career modification type diagnoses. So the authors from Australia here are really pointing out that maybe we should have a different consideration in the severity of PTSD, as they call it, PTSI, as other people call it. This also is another interesting study from South Africa that said 94% of paramedic trainees had directly experienced trauma, with 16% meeting PTSD criteria. Again, criteria even of having it or not, no varying degree. A high rate of depression, alcohol abuse, and chronic perceived stress, and low levels of social support was found. The number of previous trauma experiences, depression, resilience, and social support significantly predicted PTSD status and depression had a mediating effect. So this data was really interesting to me too, is that, okay, so we know that 94% of paramedic students had experienced trauma, with 16% meeting the criteria. And, what does that mean exactly? That's in the DSM diagnostic tool. But I thought what was most interesting is the number of previous trauma exposures, depression, resilience, and social support significantly predicted PTSD status and depression had a mediating effect, suggesting, like I said before, if we can measure students' ACEs scores and their resilience numbers, maybe we can predict students that may, or are at least more likely to have traumatic stress as a result of clinical rotations. And what can we do to, enhance potentially our educational opportunities for these students or for every student? But it's interesting that this also agreed to this. Just a couple more here. This was out of Canada in 2017, which also results suggest that developing skills to mitigate and manage workplace trauma can reduce or help mitigate the negative impact of exposure to trauma and potentially reduce the risk of developing trauma related to mental health problems, which may impact the well-being and quality of life of students once they're employed as a paramedic. So again, this is suggesting that potentially we can create educational opportunities for students to understand trauma and understand post-traumatic stress or traumatic stress and what it does to them, and potentially it can help prepare them for what they're going to see. Very interesting. And lastly, this is again from 2021 in Australia. Paramedics responding to emergencies have proven to have an impact on their mental health and well-being, therefore measuring and initiating resilience promotion and development during the educational process could promote health in this group. So again, creating resilience education and what does that look like in our curriculums, and how can we do that, and what does it look like, could indeed show some value. So with that said, I want to challenge you to this question, because this is interesting to me, and this is something that still boggles me. Is resilience earned or learned? So we have a couple of different cohorts. We have a satellite program with a fire department, and we have nurse to paramedic students. These students, and really even older students that are non-traditional, typically have higher resilience numbers. Not always, not always, but most of the time. So my question is this really resilience, or is it experience? I mean, do you learn resilience better from education or experience? We're looking into this. This is something that boggles my mind a bit about, well, or is it not resilience? It's just a coping mechanism. And, people that are on the job for 20 years, 15 years, even 5 years are showing that they have a higher resilience numbers. But I really wonder if it's really resilience or if it's just a coping mechanism. And I kind of laugh when I tell this to students in our classrooms that, at some point, if you continue to put your bad calls in a Rolodex, someday they're all going to fall out. And then they look at me like, well, what the heck is a Rolodex? Which helps me realize how old I am. I don't even talk about Johnny and Roy anymore. Nobody even knows who they are. So the interesting thing about that is, I worry that, are these people really resilient based on their experiences, or are they just coping? And is their coping mechanisms really effective? Because the people that I know that have committed suicide were resilient and didn't have traumatic stress or never talked about it or had issues. Some did, but not all. So that's kind of where I'm at with that, trying to figure it out. So what are my next steps? What are our next steps? And even challenging you all who are watching this, what are our next steps? Acknowledge paramedic students excuse me, who are experiencing traumatic stress as a result of clinical rotations. I think that's the first thing we need to start with is indeed students are experiencing traumatic stress as a result. They're reaching out for help. They're asking for help. They're willing to sit down and talk to faculty as a first step, and are willing. Most students that we've had on our program were willing to go talk to a licensed mental health practitioner. So please don't be afraid to sort of recommend them. Look at the options in your schools and where you're at. Explore options to determine, predict students who are more likely to experience traumatic stress. Use the resilience scales, ACEs scores. If you look up any of these you can Google any of this stuff and it'll show you an ACEs score, an ACEs tool. Now, I will tell you this, ACEs scores are something you likely should probably get permission from a dean level person or someone higher as to if this is okay, because an ACEs score exam can be pretty traumatic. I mean, it's asking you stuff about your traumatic childhood and what that looks like, and is there, and some of the questions are, were you abused? Did your parents, were they alcoholics, or did they do drugs in front of you? Now it's a 10 question scale, and we don't even need to know what the numbers are in each individual. We just need the N number. So typically students come in with 1 or 2, maybe 3. But it's interesting, in my prison work, when I teach in the prison, I think the average of most classes are 6 or 7. And I've seen plenty of 10s, lots of 8s and 9s, but over 6. So you can see that how ACEs scores predict, or at least predict the likelihood of this happening. So this would be helpful to know. Explore ways to integrate additional mental health into the paramedic and EMT curriculums. I've talked about this a lot today already, especially, and I kind of left out EMT, but there's no different. I mean, this is EMT, EMR, AMT. Everyone should have potentially more mental health opportunities in there, because some of the smaller places, smaller towns, are where they're going to potentially see these people too and not have the resources. So potentially we can prepare our first responder, pre-hospital type clinicians to be more prepared. Next, explore opportunities to flag students who have been on a trauma-inducing experience through the tracking software. So whatever software tracking you use, this is another good opportunity where students are putting in that they've been on this call. It might be a great time to generate an email at least, or even talk to them after class, like, hey, I saw you were on this call on your last clinical shift. How's things going? Are you doing okay? Is there anything we can do to help you? Or anything we can do to talk about it, or how did it go? Those sort of things, just to introduce the conversation. Now, some people in some academic institutions kind of view that as, well, that's kind of overstepping, and that's not necessarily my job. Well, I think it can be. I think we can at least be that gatekeeper of, hey, like, how are you doing? Is there something I can do? It just shows that we're there to help our students get through this. So explore opportunities for intervention. We talked about this quite a bit already. Enhanced, mental health education, even the additional certification. But I think sort of the foundation of all of this is explore opportunities to decrease the stigma of traumatic stress as a weakness. We look at people that are retired or medically retired because of post-traumatic stress, not necessarily with the same view as if somebody is out medically retired because of a back injury. So it's just a different stigma, and it's something that happens to lots of people. And how can we decrease that stigma? But I think the very first step is to view post-traumatic stress as an injury and not a disorder, which is a huge thing. People are even starting to move it to PTSI instead of PTSD. And I think that's a good move. People want to avoid being labeled with a disorder, especially a mental health disorder in our field. So where do we go from here? So I've talked about a lot of things that we've discovered in our program and in our university with our paramedic students. And a lot of the things are kind of what I just talked about, just not necessarily to rehash them all, but just some things like, is resilience better learned through education or experience? These are just additional opportunities to explore more research, more data. As we know, paramedicine doesn't have a lot of research and data out there that we publish. So what can we do to look at this more? How do we add more mental health into our already packed paramedic curriculum? We've talked about this a bunch today about we need to add this, but where? I mean, how do we do this? How do we jam pack more stuff in there? And, is a 1-year certification course the answer? That's a whole nother box to talk about, but where do we add this? Examine current strategies for caring for a patient with mental health crisis or complaint. So we talked about that too, kind of as a side note. What is our students' educational readiness for patients with mental health complaint? If we're teaching them to be able to take care of patients with a mental health complaint, they're probably a lot more likely to be able to take care of themselves, or at least understand that there's a problem. Strategies to provide better care for patients with a mental health crisis or complaint. So, these are also things that what do we do currently, and is that okay? But maybe what can we do is kind of what I was getting at there. What is the ideal way to take care of a patient with an acute mental health complaint? And then lastly, explore the value of measuring ACEs and resilience scores. So although ACEs could be a bit controversial, it's really helpful to understand some of the trauma that these people have already been through. And, you don't have to even know what it is. They can just simply write 2 at the bottom of their tool. So at least where they're at. You don't have to circle the bad things that's happened to yourself. You can just put a number. It gives you a better idea, and you can match it with resilience scores, and to see if this is potentially a student that's going to have some issues. And you don't even tell them that, hey, look, we know your ACEs scores are low and are high, and your resilience scores are low. We're expecting you to have post-traumatic stress. That's not it at all, because not everyone has post-traumatic stress with those. It just gives us as educators and program directors an idea of what students that potentially we need that could have issues with the things they see. Determine a plan for students seeking mental health options. So what is it that, what does your college, university, whatever have for students that are having mental health problems? Or even your town, if you're teaching EMT classes in a small town, is there some resources for them if they experience something horrific? And then explore opportunities to expose students to mental health for patients as well as for self-care, with a goal of lowering the stigma. I know I'm kind of talking about this over and over and over, but it's so important to me to, the whole goal of this is lowering the stigma and potentially making it kind of a normal part of going to school, that we talk about mental health and talk about self-care, that hopefully as we continue to migrate from school into the workplace, that will go with them. If in school it was very normal to talk about mental health problems and talk about calls that were bothersome, then potentially that can happen in the workplace and make our workplace a better place for our people. And then lastly, and again, I can't stress this enough, change the view of traumatic stress as an injury that can be healed rather than a career-ending disorder that someone either has or does not, rather than measuring the various degrees. That's kind of based on the research. It's, I don't think if you hurt your back, you don't just say, well, you have a back injury, that's it, sorry. I mean, you could do lots of different back things, and you could just have a simple thing that gets fixed in a couple of days or gets better. Well, post-traumatic stress can be like that too. So we need to find some various ways to measure this. So with that said, these are my references. These are all of the data that I gathered for this. And that's all I have. Thank you so much for your time and attention. Hopefully this was valuable for you. And hopefully it makes you think a little bit about our students that are out there experiencing traumatic things every single day.
Thank you so much, Ryan. We do have 2 quick questions here.
Okay.
Matthew asks, did differences between pediatric versus adult or elderly show up in your data?
That is an amazing question. And we did not separate it by age groups. We just separated it by just the experiences. So obviously I think we would all agree that it's probably more traumatic for pediatrics, but yeah, we didn't separate that, but that's an outstanding question.
And then our last question is from Lori, and she asks if you would please repeat the name of the evaluation system that you've been using for 8 years.
Sure, it's the resilience scale. It's from Wagnild, WAGNILD, and Young. And if you Google that, it'll bring you to the website. And unfortunately, or fortunately, you have to pay to use that. But it's not terribly expensive. It's about $1 a student to measure that. So that's what I've been using, and it's been really valuable for me.
All right. So if anybody else has any more questions, you can feel free to type those in. But if not, I did put the link in the chat to obtain the CEU if anyone's interested. So I'll leave that open. But Ryan, thank you so much for being here with us today and talking about such an important topic. This will be posted to our YouTube channel, so you can always access it and reference it. And then I will make sure that link goes out to everybody tomorrow as well. So
awesome. Thank you so much, everyone. Appreciate you.
And thank you so much, Ryan. We really appreciate it.
All right. Take care.
Have a good day.
You too.